My charge today really is to talk about arthroscopic intervention for hip pain. I think it's a pretty vague topic, and I think it sort of behooves us to try to understand hip pain a little bit better. So these are my disclosures. And I definitely want to acknowledge the members of the hip group, and in particular some of the outside members that have helped me with some of the videos that we have here, including Chris Larson and Mark Philippon. So, this has already been covered, but this is the hip anatomy. And as I had mentioned before in answering the question, the most important part about the hip really is the articular cartilage and the articular surface of the joint. So it's all that white stuff. That white stuff is your joint. As that articular cartilage degrades, you lose the ability to move, you lose the ability to function, and I think that's when you're a candidate for a total hip replacement. So in what we're trying to do with hip preservation, we're trying to, in actuality, what we're trying to do is preserve the articular cartilage. The labrum, as you've been hearing over and over again, it's a secondary victim. We hear a lot about the labrum, it's a very hot topic, but it's a secondary victim of what's going on. And so what we are trying to do is treat the primary problem. These are some of again, going through anatomy, this is some of the soft tissue stabilizers of the hip. This goes in with Brian Kelly's layers concept, what Dr. Demacourt had already touched upon. The main ligament that we go through is actually the iliofemoral ligament. We actually cut through that ligament in order to get access into the hip through the arthroscopy that we do. The function of the hip capsule really is to provide stabilization of the joint and proprioception. And the reason I bring this up is it's the iliofemoral ligament resists external rotation, and that's one of the reasons why post-surgery, post-arthroscopy at least, and particularly if we haven't closed the capsule, we don't want, a lot of the therapists, we don't want the rehab to include a lot of external rotation, because that will actually pull on what we're trying to get to heal back down. So in particular, if we do a capsule application, or if we do some sort of capsule repair, or if we don't repair the capsule at all, we don't want that external rotation in the early term preoperatively. The acetabular labrum, we truly don't really understand what the role of it is. It's a mechanical, we do think it plays a mechanical role in keeping the fluid inside the hip joint. That reduces the contact pressures of the force, of the joint reaction forces. It probably enhances joint stability. And importantly, there's nociceptive fibers in it. And that's probably the reason why we hear so much about it. And that goes to what the topic of the talk, hip pain. A lot of pain can be caused by tears or abutment of the bone against the labrum itself, because the labrum has a lot of nociceptive fibers. So in terms of hip pathology, a significant part, the majority of the pain that we term hip pain is located in the groin. Some people will say it's in the back. Some people point to their sides. Some people point really, really medial. But in general, when we start hearing groin pain, we start thinking of the hip. The patients oftentimes, because there's some sort of bony abnormality, will have this hip pain in conjunction with a loss of internal rotation. So if you have a patient who presents to you who you really cannot internally rotate, or they have pain with internal rotation, you got to think about the hip. So in terms of nociception, this talk is about hip pain. I think that's something that we probably truly as a group, as a whole, don't quite understand. Again, it goes to the point that Dr. Straccolini made. You've got patients who have, whose legs are falling off and they have very little to no pain. And you've got patients who have the smallest labral tear in MRI and they're on crutches and they're just incapacitated. So I don't think we truly understand all the pathways and exactly what's going on with the nociception. But if you start thinking about where are the pain fibers, you have pain fibers in the bursa, you have pain fibers in the muscle and tendons, and so the layer 3, which is which goes back to Dr. Kelly's layer, with the muscles, you're going to have pain fibers in those areas. So the muscles themselves, the tendons, etc., can cause pain. The ligament likely has nociceptive fibers, and the capsule, which is the capsule of the joint. So if you get hyperlaxity, if the joint's stretching out, if it's moving around quite a bit, there's probably a role in that playing a proportion in generating hip pain. The labrum, as I just mentioned, a lot of nociceptive fibers. That has a role in generating hip pain. And that's why I think so many people right now are focused upon the labrum as a diagnosis, and everyone starts saying, oh, they have a labral tear, so that must be the cause of their pain. The important thing is what Dr. Millis had mentioned is the cartilage. And as I said before, that's your joint. You lose your cartilage, your joint's hosed. The cartilage itself has no nociceptive fibers. You can't feel when you're damaging the cartilage. And I think in essence, that's probably the most important part of the joint. That's what we're literally trying to save with hip preservation, is save your cartilage so that you don't have to have a hip replacement. And that's the important take-home message. The cartilage doesn't have pain fibers. And oftentimes, if you have a cam lesions, for instance, in FAI, once you've damaged the labrum and the labrum's starting to scream, the cartilage has already been damaged, perhaps to a point beyond which we can salvage. The subchondral bone itself, the bone underneath the cartilage, does have nociceptive fibers, and that's probably why patients with bone-on-bone type of arthritis have pain with that arthritic type, they generate arthritic type pain. So it's always funny to me, the most important part of your joint has no pain fibers. So as we go through what causes hip pain, I'm going to go through a fairly long list. These are what I would consider interarticular sources of causing pain around the hip joint. So labral pathology, we know it has, if you have a tear, we know it has nociceptive fibers, that's going to hurt. Ligamentum teres, which is the ligament that connects the acetabulum to the femoral head, that has nociceptive fibers in it. That, if you have a tear in that could potentially hurt. Synovitis within the joint can cause pain. Chondral pathology, so if you have a flap of cartilage that perhaps is rubbing that against the labrum, perhaps that's causing pain. Femoral acetabular impingement, the bony abnormality, that has a potential of causing pain. I'm not exactly sure exactly how that might be causing pain. Perhaps it's as you impinge and you bump up against the labrum, which has the nociceptive fibers, that potentially is the cause of the pain. If you have loose bodies floating around in the joint from either benign or malignant tumors, avascular necrosis, degenerative joint disease, etc., or other dysplasias, those can generate pain. So that's a pretty short list of things that can cause pain from an interarticular pathology. The longer list actually is what causes pain from the extraarticular sources, so stuff that's actually outside the hip joint. You could have a snapping hip that Dr. Straccolini talked about, both internal and external. So the internal snapping hip is caused by the iliopsoas. The external snapping hip is caused by the iliotibial band. You can have bony impingement outside the hip joint. You could have subspine impingement that was presented earlier, where you get the anterior inferior iliac spine causing impingement. You can have trochanteric impingement, like Dr. Kim just presented. You can have ischiofemoral impingement, which occurs in the buttocks. So there's other types of bony impingement that can occur extra-articularly. Additionally, you can have muscle strains. You could have tendinitis of any one of the 26 muscles that cross the hip joint. So, in particular, as Dr. Democrat already alluded to, the iliopsoas, your gluteals, your adductors, your hamstrings, these are all big joints. These are all big muscle groups that can cause joint pain or hip pain. You can have bursitis, trochanteric bursitis, iliopsoas bursitis, ischial bursitis. These areas can cause pain around the hip. Again, you're getting the picture. A lot of extra-articular sources of hip pain and not as many intra-articular sources. Avulsion injuries, avulsion fractures, you can have stress fractures, you can have osteitis pubis, athletic pubalgia, you can have capsular laxity. So these are all things that are outside the hip joint itself. So this all, this is the layers concept that Dr. Kelly has espoused, and I think it plays a big role in the understanding of what generates hip pain. If you look at the osteochondral layer, which is your first bony layer, if you have an abnormality in that layer, that can affect all the layers above it. So oftentimes, if you have a labral tear, it's, as we've heard before, 90% of the time it's caused by some sort of bony abnormality. So you have a problem with layer 1 that's causing a problem in layer 2. As you have that occur, what can then happen is your contractile forces, your muscles around the hip joint are trying to protect it from perhaps moving as much. They contract perhaps more forcefully or too much, and then you start having problems with the muscles themselves. So I think every layer builds upon each other, and you can have pain that's caused in layer 3 that's directly a result of what's going on with layer 1. So I think that has to be in the back of everyone's mind when you're thinking about what is causing the pain that you're seeing in the patient that you're treating. So these are the conditions that are amenable to treatment with hip arthroscopy. As Dr. Kim said, we're orthopedic surgeons, so what we do is we change the structure of the bone. Unfortunately, I don't have patients that come to me and say, hey doc, I don't like the way my femoral head looks. Can you reshape it for me? I have patients that come and say I have pain. Now, literally what we can do at the time of surgery is we can change the shape of the femoral head. We can change the shape of the acetabulum. We can repair the labrum. We can do these things that to some of the muscles and the tendons. But if that truly isn't the source of their pain, I can have a really pretty x-ray afterwards, but they may not be better. And I think that that's the biggest thing, that's my biggest take-home message, is that I think we have to understand what's causing their pain in the drive to try to help treat them. So what can we treat with hip arthroscopy? Femoral acetabular impingement, we're getting pretty good at doing that arthroscopically. We can treat labral tears, traumatic labral tears. You can treat chondral lesions. You can treat capsular laxity, so we can plicate or sew up the capsule. We can treat ligamentum teres injuries. And we can take out a lot of loose bodies. So there's not a whole heck of a lot so that's really what we can do in the inside of the hip joint. Well, what can we do outside the hip joint? That's ever expanding. There's more and more people that are trying to push the envelope in terms of treatment. We can treat snapping hip, both internal and external. We can treat subspine impingement. We can get rid of the bone that's just around the hip joint. We can treat gluteus medius tears. So these are all conditions these are all things that are outside the hip joint that we are beginning to treat. We're not so good at treating muscle, muscle inflammation. We're not so great at treating perhaps like tendinitis. But we're pretty good at treating the bony pathology. And if the bony pathology is the reason for the pain, I think that we can do a pretty good job. So again, we focus on labral tears. Why do they occur? Dr. Mills and all the other speakers have focused on this already. Why do they occur? Usually repetitive activity. And I think the key thing to understand is you can have abnormal anatomy, FAI, dysplasia, something like that, where the anatomy is abnormal, and you take the hip through a normal range of motion, and you can present with the labral tear. So patients who have FAI, if they sit, they're going to start impinging. They can bump up against that labrum. They can cause a labral tear. So you can cause a labral tear just by sitting down, in the auditorium. Or a lot of our dancers, some of our hockey goalies, etc., they have relatively normal anatomy. Their anatomy looks pretty good, but they take their hip through an abnormal range of motion. I think the treatment for those, for those patients would be stop that abnormal range of motion and stop dancing, but unfortunately that usually never works. So how do labral tears present? It's usually insidious onset. The location, again, is mostly the groin, but you can get it laterally. You can get it in the buttocks. A lot of patients have night pain, so these are all things to keep aware of, to keep in mind. The pain pattern, the pain referral patterns are not really cut and dry. So I think that's one of the reasons why a lot of the times we rely on Dr. Demacourt and Dr. Stracolini with these injections to actually help us determine where is the pain truly coming from. So in terms of arthroscopy, again, we've gotten a lot better. There's been newer instruments that have been developed. People have gotten better in terms of their experience level. So we're a lot more capable of treating a lot of things interarticularly. So in essence, it's the bony pathology. And as Dr. Mills already alluded to, a lot of these soft tissue injuries, the cartilage damage, the labral tears that occur because there's some bony abnormality. And what we can do, again, is whether it's open or arthroscopic, is we can correct that bony anatomy. So this is a very simplistic decision tree, but you have a patient that comes in who presents with hip pain. Every single patient who presents with hip pain, the first thing we're going to try is conservative management, whether it's physical therapy, whether it's acupuncture, whether it's alteration of activities, etc. We try conservative management first, and if that works, game over. If it doesn't, and we're still trying to figure out where the hip pain's coming from, is it the muscles around it? Is the joint itself? I utilize a lot of differential injections, so we'll inject around the bursas, or we'll inject into the joint itself. We ask the patients to keep a log of how their pain, either decreased or increased, or whatever the case may be, and that gives us an understanding and a diagnosis of where the hip pain's coming from. If they do well with the injection, I'll send them back to conservative therapy, see if we can improve them. If we can, then we're done. If not, they failed conservative management. They failed. The injection sort of proves that the pain is coming from the joint itself, and everyone agrees to it. Then what we'll do is a lot of times then we'll take those patients to surgery, and hopefully they get a good result. So hip scopes, again, this is the newest thing. It's the new hot frontier of medicine. It's probably where the shoulder scopes was about 25 years ago. Now everyone does shoulder scopes. It's getting to the point where more and more practitioners are learning and doing hip arthroscopy well. It's something that's significantly growing in popularity. So the first thing you need to do when you get a hip scope is you need to get a pretty big room. There's a lot of equipment for the hip scope, and the biggest thing really is the fact that you have to do this under fluoroscopy. Again, it comes down to the point where what we're trying to do is change the bony anatomy. So, unless you have X-ray vision or you're that good, you don't know exactly what you're changing. So we use fluoroscopy a lot, and that machine is really pretty big, and you've got everything else in the room as well. So typically, hip arthroscopy can be done in a supine approach, or a lot of joint arthroplasty surgeons like to do it in the lateral approach. I don't think it really makes that much of a difference. We do it with the supine approach here. And these are the typical portals that we use. And this looks like sort of like a treasure map, but typically this is with the location of the greater trochanter, where we'll mark it out. This is the location of the anterior inferior iliac spine, or anterior superior iliac spine that you can palpate on yourself. And typically what we'll use is a combination of 2 to 3 portals. I'll use this anterior lateral portal here as well as this mid-anterior portal. There's some of us that use a posterior lateral portal as well, and some of us will use an anterior portal. So it doesn't matter what portals you use. I think it's all just ways we're trying to get into the joint and trying to do what we want to do. So in terms of arthroscopic technique, the first thing we do is we go into the central compartment. Once you're in the central compartment, that consists of the articular surfaces of the bone. You can do stuff to the cartilage, whether you smooth it down, whether you do microfracture, which is designed to try to salvage a significant cartilage defect. You can do rim trimming of a pincer lesion. You can do labral repair. You can do labral debridement. You can reconstruct the labrum. You can also take care of things within the cotyloid fossa and the ligamentum teres. Once you're finished with that, you then move into the peripheral compartment, where you can actually look back and see how good your labral repair was. And then you do the osteoplasty of the cam lesion if there's one there. And you can also do capsular modifications, whether a plication, a closure, or just leaving it open. You can work on the capsule at that point as well. Also out in the peripheral compartment, you can work on the subspine if you're looking at subspine impingement. So this is what a typical arthroscopy looks like. This is entry from the anterior lateral portal. This is the first view in the joint that you get. This is the femoral head right here. This is the labrum right there. This is the little capsule area. This is soft tissue. We call it the anterior triangle, and that's where you're actually aiming to put your next portal. The next step after you establish that is you actually do a capsulotomy. So in order to move around the joint, it's a round joint, it's a deep joint, it's hard to move around. The next thing you want to do is actually do an incision in the capsule. So we actually incise the iliofemoral ligament. So we actually, we do it from portal to portal. And again, that's the reason why post-operatively we don't like a lot of external rotation. This is a view of the labrum, shows the vascularity of the labrum actually comes from the capsular side. This is the anterior labrum, here's the acetabulum there. This is the posterior labrum here. This is the posterior acetabulum against the posterior femoral head. This is a view of the ligament of a normal-looking ligamentum teres without any evidence of any tearing. This is the anterior aspect of the femoral head, which you can see really pretty clearly. You can see the posterior aspect of the femoral head. So you're getting to the point that we can see a lot of the structures within the joint really quite well. This is a view of the anterior head-neck junction. This is looking from the anterior portal. This is the actual head-neck junction itself. This is a view looking down the recess, where you can actually look all the way down to where the capsule connects on the proximal femur. And this is a view of the lateral retinacular vessels. So these are the vessels that supply the femoral head. And if you can see here, if you can see this visualization here, there's the beating of the vessels which are feeding into the femoral head. So you can see them beating right there. So you can do your section up until that point. You don't ever really want to hit those blood vessels if you can help it. So this is a slide from Mark Philippon. I've actually haven't scoped a normal hip or a hip that looks normal. So I really don't know what a normal hip looks like. I think this is what it's supposed to look like. So this is a normal suction seal. This is the labrum here. here you get a nice concavity of that femoral head neck junction. So this is a hip that, you know, if you describe it, it looks just like a light bulb. And so that's the way I describe it to my patients. You want the hip, the ball, and the neck, which goes into the middle of the femoral head, you want it to look just like a light bulb. And this is light bulb looking. So look, you know, once you get established entry into the joint, the first thing you're going to do is you're going to look in the joint itself. And here's a video of, here's the labrum right here. There's a tear right at the chondrolabral junction. The cartilage underneath is quite softened. This is consistent with a cam damage. But the first thing you want to do when you get in the joint is identify the pathology that you have to deal with. So what's one of the things that you can do in the inside of a joint? You can do an acetabuloplasty. So in this case, this was a case that that I borrowed from Mark Philippon. He had, at that point, had detached he was going to do a fairly large rim trim, and he had detached the labrum at that point. And then what he's doing here is, what we're doing here is we're taking the burr and we're actually burring out the rim. So the labrum is the structure right up, this fuzzy stuff right up here. Here's the actual bone of the acetabulum, and you can see the resection down to the more yellowish type bone. But you can see that the labrum has been detached, and here's the burr kind of trying to smooth down or trying to decrease the amount of acetabulum that you have. So you can actually trim out the acetabulum. And typically, you usually end up taking about 3 to 5 millimeters of bone away. The biggest thing that you don't want to do when you're doing an acetabuloplasty is you don't want to resect too much. You don't want to take a patient who has FAI and then turn them into a patient who now has dysplasia, because you've really you screwed it up if you've done that. So this is a case in which you can see here's the anterior wall, here's the posterior wall of the acetabulum. This is after the acetabuloplasty. This crossover sign, as people call it, has been removed by taking off that small 3 to 5 millimeter rim of acetabulum. So this is that same patient now doing, the labrum's been detached. We're actually going to reattach the labrum. So this is a video showing the reattachment of the labrum. You actually drill a hole as perpendicular to the acetabulum as you can. This is an anchor that's being pushed into the acetabulum itself, and then we'll use tools to pass it around the acetabulum. So here's a suture that comes out of it. We'll use this tool to pass around the acetabulum. You can either sew it through the acetabulum or the labrum itself, or you can loop the suture around the around the labrum. This one was looped around the labrum, and we're tying the knots and trying to put the knots on the acetabular side so they don't rub up against the femoral head. But this is a video just demonstrating the repair now of the labrum that was taken down of that patient that we did before. So here is the labrum. It's been reattached to the acetabulum, which is back here. And this is the knot cutter, which then cuts the knot. But the labrum has then been reattached. And that's very similar to what we would do with the labral repair. If we don't detach the labrum, we do the same thing. And this is actually a view from the peripheral compartment, which can show that here's our labrum, which has been repaired. You can see the stitches, and you can still see that it keeps that suction seal to that femoral head really pretty well. What else could you do in the inside of the joint? You can treat chondral defects. So here's a patient with very, very large chondral flap. This is not a good situation. This was actually a hockey player of mine. We actually had to take down this femoral flap, and we actually ended up doing microfracture on him. But you can do a chondroplasty, which is just taking a shaver and just kind of smoothing down any cartilage fibrillations, or if they're down to bone, then you have to do something, a salvage procedure such as microfracture. And the microfracture will alter our weight-bearing status after the surgery. So this is some pictures of a microfracture. This was done on the femoral head for femoral head defect. This was done on the acetabular side, where you can see these little punctate holes that we poke into the bone, and we actually get that will fill in with the blood clot. That blood clot will actually fill into that area, and eventually it will turn into fibrocartilage, which is not nearly as good as the articular cartilage that we used to have, but at least it gives you some kind of covering. So once you finish in the central compartment, you can then go into the peripheral compartment. You can do an osteoplasty. Shown in these videos. This is just a video showing, and Dr. Kim already sort of showed a video on this as well. This is just taking off the bone off the femoral head neck junction. Here, this is a patient of mine in which it's a small mild cam lesion, but what we did was after the osteoplasty, you can see the increase in the femoral head neck offset. This was a hockey goalie with a huge cam lesion. This is after the resection, so you can see the recreation of that head neck junction. You can also do it superiorly, so this is a patient who had a bump laterally that we removed as well. So this video was borrowed from Chris Larson. This is a dynamic examination showing your decompression. This is a patient with a very egg-shaped looking femoral head. You see the labrum has already been repaired. And you can see it's just really not going into the socket very well. And this is after the osteoplasty was done. You can see a huge amount of resection, and all of a sudden you get a significant improvement in your range of motion. And that's what we're trying to achieve. We're trying to make that light bulb shape of the femoral head neck junction so that the patient can improve their range of motion. Postoperative protocol, we use medical pharmacology to decrease your DVT. We also decrease heterotopic ossification. Our postoperative protocol is I usually do about 20 pounds foot flat weight bearing. I don't want to activate the psoas. We use a CPM machine for 2 to 8 weeks, depending upon whether we did a microfracture or not. And sometimes we modify it if we have to do a lot of capsular repair or chondral repair. We start first with passive range of motion and then work out to active range of motion. The goal really is to try to get patients back to function at around the 12 to 16 week mark, although usually I quote patients about 3 to 5 months of recovery time. In terms of FAI outcomes, there's been multiple studies now that have shown that the outcomes really are quite good. This is published by Bird. These were all actually labeled debridements. This was done by Dr. Koch here, which showed excellent improvement in children and adolescents for a variety of diagnoses. This was also Dr. Philippon's study on adolescent athletes, and this was a bigger study on older patients who underwent FAI, but everyone had improvements in their activity level and their pain scores. Some of the other things you can do with arthroscopy: you can take out loose bodies from arthritis, from childhood dysplasia disorders, Perthes, synovial it's not super fun. You're sitting there just kind of picking out loose bodies. Capsular laxity, you can address capsular laxity. So again, this is a schematic showing what we do at the time of surgery. We cut that iliofemoral ligament from portal to portal. So there's a hole in that capsule. This is a patient that we actually did yesterday where we repaired the capsule after we did that. If you can do a plication, you can do like a pants over a vest. You can put one suture here and use it here to actually plicate and advance the capsule as well. Dysplasia, arthroscopy can be thought of as an adjunct to treatment. I would certainly not use it as the primary arthroscopic intervention. This is a patient who we did, actually she was yesterday. She had a very large hypertrophic labrum, had a labral tear. We fixed the labral tear, and then the periacetabular osteotomy was performed after the arthroscopy was done. Snapping hip that Dr. Straccolini touched upon. You can do a recession of the iliopsoas. So if you have irretractable snapping that it's just not improving, it's not getting better with all the stretching in the world, etc., it may come time to do some kind of surgical intervention. You could release it at the pelvic brim, you can release it at the level of the capsule, or you could release it at the level of the lesser trochanter. Depending on where you release it, Bloomberg and actually it was Keene from Wisconsin showed that releasing at the pelvic brim is probably about 40% tendon, 60% muscle. As you go down, you get more and more tendon. So you never truly release 100% of the tendon, but that being said, some of the complications that can occur after psoas release is weakness of that in hip flexion. So most of the studies that have been presented have shown good results with this. Fabricant recently reported on if you have increased femoral aneurysm and you have instability issues, releasing the psoas is not a good idea. So this is a video showing this is where the labrum is right here. I've opened up the capsule a little bit more to expose the psoas tendon. You can see the tendon fibers here being cut and released. And apparently I'm struggling. I haven't released it. At some point it gets completely released. Oh, right there. Okay. Poof. External snapping hip. This is a patient with external snapping hip. This is where, so the way we describe the snapping is external snapping hip you can see, internal snapping hip you can hear. So this is a patient with external snapping hip. You can see as she flexes, you can see the pop of the iliotibial band that pops back as you move. She couldn't go up and down the stairs without trying to just keeping her thigh in abduction. And so that one is a really pretty prominent case of external snapping hip. Typically what we do, you can do it open or arthroscopic. Yeah, essentially what we're trying to do is open up a window in the iliotibial band so that it prevents snapping against that greater trochanter. So this is showing the needle here. Right there is right at the tip of the greater trochanter. And what we're doing is we're looking at the iliotibial band here, and we're using cautery to kind of open up this a longitudinal incision in it. And you can see the bursa underneath. You can debride the bursa at the same time. And eventually, I'll actually, get the triangle opened up. Maybe it's not super important. So we're opening both proximally and distally at this point, and then you start taking the device and you go posteriorly to open up this posterior band. This posterior aspect, you can see how thick the band is right there, and how much more thick this band is posteriorly, and that's usually the location of the snapping. So we can actually do a fairly good job at getting rid of that snapping with the external snapping hip. So in conclusion, the FAI really is now a widely accepted concept. Both open and arthroscopic techniques have yielded good early to midterm results. I think that a lot of people are doing arthroscopy. I think there's a fairly high learning curve to it, though, and so you have to maintain a high volume in order to be good at it. So hip arthroscopy can be used for bony reconfiguration, and we can use it in some aspects to change some of the soft tissue. So the IT band, the iliopsoas, we can fix the labrum, we can tighten the capsule, but we really can't touch the muscles around the joint. The biggest question is that the source of the patient's pain? And if that really is the source of the patient's pain, if the labrum is the source of the pain, if it's the bony impingement that's the source of the pain, we could do a pretty good job of helping them. If not, we rely on other methods. Thank you.